in that very high group. So MAPLE does predict caregiver distress, but there is some interesting diversity within MAPLE categories between diagnostic groups. If we look at the prediction of nursing home placements using the MAPLE algorithm, what we see is that the MAPLE is highly predictive of actual nursing home admissions, in this case using Parkinson's populations. So in the low MAPLE level, less than 5% were admitted to nursing homes within 6 months of the assessment, but for the very high MAPLE level, about 45% were actually institutionalized in that follow-up period. So in the Parkinson's population as well as others, MAPLE did predict that outcome. The CHESS scale is one that's being used to predict mortality, acute hospitalization. It's an indicator of medical instability where scores of 5 are highly unstable, 0 are stable with respect to their health. This looks at the MS population in complex continuing care and looks at a survival curve, time to mortality, based on the CHESS scale. And if we look at people with MS in complex continuing care, in a 6-month follow-up, about 30% of the people at the lowest scores have died, but that's compared to almost all the people at the highest scores having died within 80 days. There's actually huge differentiation in the mortality experience in the MS population, but we see this in multiple other populations, including people with ALS. And I'll end off with a data example related to costs of care, just to show that when we linked data on formal service use combined with shadow costs of informal care for home care clients, we see considerable variability in the costs of care of home care clients with different neurological conditions. So people with any of the neurological conditions cost more than people